This is the patient assessment trauma skill. Our scenario today is a 25-year-old male struck by a car while walking across an intersection. First, I want to make sure I have on my BSI, my gloves and safety glasses, and that the scene is safe. Next, I make sure I have one patient. It appears to be a mechanism of injury. I'm going to call for additional resources, including fire, police, rescue, and that I'm going to have my partner establish inline stabilization of the head and neck. I'm approaching my patient. My partner is going to take that inline stabilization. I'm getting my general impression of the patient. Appears to be a 20-something-year-old male lying in the middle of the street. His eyes are closed. An unstable patient. Looking for any life threats. I do see an open, obviously angulated tib-fib fracture. It appears to be bleeding, blood squirting out. I'm going to apply direct pressure to the bleed. Doesn't stop the bleeding. I'm going to have my partner come in and apply a tourniquet 2 inches above, as close as possible to the wound. The tourniquet takes care of the bleeding. Bleeding is now controlled. I'm going to continue my assessment by checking level of consciousness. Sir. There's no response to touch or talk. Apply painful stimuli. Patient has flexion posturing. He's P on the AFWO scale, and his chief complaint now is a altered mental status. I'm going to have my partner open the airway, jaw thrust, looking inside the mouth for any secretions. I do see there's blood and vomitus in the mouth. I'm going to suction the airway. I'm going to suction no more than 15 seconds and only on the way out. I'm going to measure from the angle of the jaw to the corner of the mouth. Secretions have been cleared out. I'm going to consider supporting that airway using an adjunct, an oral or nasal pharyngeal airway, because he does have that flexion posturing. He probably has a gag reflex, so I'm going to consider moving on and using the nasal instead. So I'm going to look for any signs of basilar skull fracture. I don't see any obvious facial injuries. I don't see any raccoon eyes or battle signs. There's no blood or secretions coming from the nose or ears. So I'm going to measure that device from the tip of the nose to the tragus of the ear. I'm going to insert the nasal pharyngeal airway, and he appears to accept that quite well. I'm going to go on to my B, breathing. I'm checking for rise and fall of the chest, adequate breathing. It appears to be inadequate and shallow and slow respirations. I'm going to have my partner come in with a bag valve mask at 15 liters and ventilate this patient 1 every 5 seconds. I am getting good rise and fall with those ventilations, and that there doesn't appear to be any injuries that I can see that interferes with his ability to be ventilated. Next, I want to check circulation. I'm going to check the carotid and radial at the same time, comparing central and peripheral pulses. He has a weak, thready, rapid carotid pulse and absent radial pulse. Skins are pale, cool, and diaphoretic. And I'm going to do a quick blood sweep. See any blood I might have missed. And I know I still have that bleed right there, but that's been stopped already. Because he's pale, cool, diaphoretic, and because he has this rapid, thready pulse, he's more than likely going into shock. I'm going to have my partner turn the ambulance up to 85 degrees, get some blankets coming my way, and we're going to establish with the oxygen and supine position, shock position. I'm going to continue my Glasgow Coma Scale. Originally, he had that flexion posturing. His eyes remained closed, which is a 1. He's nonverbal, which is a 1, and 3 for the flexion posturing, a total of 5 on the Glasgow Coma Scale. Because of this, he's an unstable patient and can be transported as rapidly as possible off scene. Next, I'm going to start my secondary assessment. I'm going to have my partner go and get a sample history, find out the speed of the vehicle, how far the patient was thrown, any other information he might have on the patient. And then I'm going to start my head to toe. I'm going to use DCAP BTLS, deformities, contusions, abrasions, penetrations, punctures, burns, tender slashers, and swelling. And run my hands through his hair, looking for any blood coming off, any lumps, bumps, or bruises. I don't see any obvious signs of deformity to the face. Palpate the facial bones. Everything seems to be stable. The pupils are reactive at 6 and appear to be pearl. I'm checking the posterior portion of the neck. There seems to be some crepitus, and when I do press gently, he flexes. So I won't continue that. I check the anterior portion of the neck, looking for any kind of deviated trachea or distended neck veins. No any sense of trauma. No sense of trauma. So I'm going to put a collar and size and fit a collar on there. I'm going to expose the chest by cutting away the clothing. I'm going to use IPA. I'm going to inspect, palpate, and auscultate. I'm going to inspect for signs of trauma. I do see some abrasions and bruising to the right side of the chest. I'm going to inspect the clavicles. I'm going to push in gently, checking for stability of the rib cage. He did some little bit of crepitus on the right side. The sternum seems to be stable. Listen to lung sounds bilaterally. Good lung sounds bilaterally with those ventilations going in with the bag valve mask. Moving down to the abdominal cavity, looking for any signs of bruising or abrasions or distension. I don't see anything obvious at this time. I'm going to find the umbilicus. I'm going to palpate all 4 quadrants. I'm looking at his face to see if he responds to my palpations, to pain so far. And then he does grimace and has that flexion posturing when I press in on his right lower quadrant. I'm not going to do that again. Go down to the pelvis. I'm going to sweep for a priapism because he's a male. I'm going to look and smell for signs of incontinence, stool, or urine. I'm going to palpate the pelvis, feeling for instability. If the pelvis was unstable, I would consider using a pneumatic anti-shock garment or some type of blanket roll once I put him on the spine board to stabilize that. Expose the legs. I'm going to stress the bones and joints of the lower extremities, looking for any instability. Decap BTLS. I know I have that fracture and the tourniquet down here. He does seem to have some swelling and bruising and shortening to the right upper leg, left upper leg here. So I'm going to consider this might be a femur fracture. Otherwise, everything else is negative. Check distal pulses. Painful stimuli. He does flex on the painful stimuli. Check the upper extremities. Does have some abrasions to the right arm. And the left arm seems to be okay. Pulses. Pinch. Pinch. He has that flexion posturing. At this point, we're going to log roll the patient using C-spine precautions. On the count of 3, 1, 2, 3. Expose the rest of the back, checking the back of the head, all the way down the back, the buttocks, the backs of the legs, get posterior lung sounds at this time. There seems to be just some abrasions and bruising to the back. Slide the board in, 1, 2, 3, log roll onto the board. Secure him to the spine board. Now we're transporting to the hospital. I'm going to get a full set of vital signs, which would include blood pressure, pulse, respirations, skins, O2 saturation levels. I'm going to treat those secondary injuries. I'm going to establish a splint to the femur fracture. I'm going to wrap up these abrasions to his arm on the way to the hospital. While I'm going to the hospital, I'm going to recheck his primary assessment, which would include his ABCs and his Glasgow Coma Scale. I would redo his vital signs at least every 5 minutes. I'm going to recheck my secondary assessment, focusing on areas that I've already checked as well as areas I might have missed. And I'm also going to recheck my interventions. Make sure the oxygen is still flowing in, good rise and fall of the chest. And make sure that the tourniquet is still stopping that bleeding, the femur is still stabilized, and the wounds are wrapped up.